So very logical question is, should we shift all patients with HFrEF who are on AC inhibitors or ARNI? When to switch? Should we wait till they become unstable? The illusion of stability is very common, which I had discussed earlier. There is an illusion that patient is stable. They are sitting on volcano. They are sitting on a time bomb. So we should do the best to have any such episode, because every admission, every worsening of heart failure can lead to mortality and morbidity. So 20% of stable patients in paradigm heart failure had a primary event. That is very important. 17% died during the course of the trial. Of stable patients who experienced a primary event, death preceded heart failure hospitalization in 51%, a good 50% patient, and 60% of those deaths were sudden cardiac. A very important clinical point is that majority sudden cardiac deaths are in patients who are NYHA class 2 and NYHA class 8. Contrary to a common belief that sudden death is more common in class 4, no. It is more common in those who are class 2, class 3. So I think they should be given the best treatment. They appear stable, but they are probably not. So RNA should be started as early as possible. Do not wait till deterioration occurs. So this is the message. So what are the recommendations for renin-angiotensin system inhibition with this or ARBs or RNA? From reference studies that support the recommendation as summarized in the supplements. Class 1A in patients with HFrEF and NYHA class 2 to 3, the use of RNA is recommended to reduce mortality and morbidity. Again, class 1A in patients with previous or current symptoms of chronic heart failure with reduced EF, the use of ACE inhibitor is beneficial to reduce mortality and morbidity when the use of RNA is not feasible. So very rarely we find that RNA is not feasible, but we can use ACE inhibitor. I have not found any clinical scenario where I'm not able to use RNA, but I'm able to use ACE inhibitor. So something like it's very important for clinician. And again, class 1 is in patients with previous or current symptoms of heart failure with reduced EF who are intolerant to ACE inhibitors because of cough or angioedema, and when the use of RNA is not feasible. Then so ARB has a very limited role in such set of population. The message from this slide is that we must use RAS blockers in every possible patient. Priority is RNA number 1. And fourth point, very important, is patient with previous or current symptoms of chronic HFrEF in whom RNA is not feasible. Treatment with an ACE inhibitor or ARB provide high economic value. So very rarely we find that patient is not suitable for RNA, and then you have to go for RAS blockade. So use ACE inhibitors and ARBs only when RNA is not feasible. So I think I have not seen any patient where this has happened to my practice. So a question, very common question comes then, is acute decompensated heart failure different from de novo heart failure? So what are the patient characteristics? Acute decompensated chronic heart failure or de novo heart failure? Older population, worse baseline status and laboratory findings, no history of underlying heart failure. On this side, no history of heart failure. As far as comorbidities are concerned, patients have ISD, very commonly COPDs, atrial fibrillation, diabetes, they have a stroke or TIAs, history of CABG and PCI is very frequent in this part. However, it's very uncommon in de novo heart failure. Then what are the triggered events? Medication, poor compliance, resistance, infections, diet, excessive sodium intake, cardiovascular complications, intervention, surgery, or any precipitating event. Alcohol, they are usually triggering events. On this side, cardiac ischemia, valvular incompetence, or acute MI, mitral regurgitation, inflammatory myocarditis, or some toxins, drug-induced, can be because of de novo heart failure. Clinical presentation is almost same: dyspnea, orthopnea, classical presentation of heart failure, ascites, weight gain, limb swelling, raised ABP, orthopnea. It's very common presentation. And this side, usual presentation is cardiogenic shock or pulmonary edema. Then main physiology is, if you look at the main pathophysiology, pulmonary systemic vascular congestion caused by LV dysfunction, maladaptive neurohormonal activation, fluid overload, and then fluid redistribution. Contrary to this is acute hemodynamic derangement caused by LV systolic dysfunction of acute enzyme.